Welcome back, coders, to part 45 of our Explainer series. I'm Harshal, and today we're using our Level Up system to conquer 5 major ICD10 systems. We're moving anatomically from the inside out because mentally stacking these guidelines spatially is the absolute best way to lock them in. We're breaking down the highest yield rules you need to crush that CPC exam.
But first, make sure to like, share, and subscribe to Decode Healthcare with Harshal. All right, grab your coding manuals. We're dropping straight into the action with Level 1, the digestive system.
Okay, let's dive into this. Chapter 11 gives us a really powerful shortcut called the presumed relationship. Basically, in GI coding, if a hemorrhage and a bleeding ulcer are both documented, the code set just assumes a direct link. Clinically, this makes total sense, and it saves you from endlessly hunting through provider notes just to prove the ulcer actually caused the bleed.
But right here is your first major exam trap. You absolutely cannot assume active bleeding just because there's an ulcer in the chart. Your cheat code, you literally must see explicit provider documentation of active bleeding to legally code a hemorrhage. No active documentation, no hemorrhage code. Simple as that. And this brilliantly illustrates our move to Level 2, the skin and subcutaneous tissue. When you're coding L89 pressure ulcers, depth is your guiding metric. The right code combination captures the precise site, the laterality, and the clinical stage. That stage corresponds directly to how deep the wound penetrates, from superficial skin all the way down to muscle or bone.
Test makers absolutely love to trick you here. Think of it like this. Unstageable is a clinical roadblock. The wound base is completely covered by slough or eschar, so the clinician physically cannot see deep enough to assign a stage. Unspecified, though, that's just a documentation failure. The provider flat out forgot to write it down. You really got to know the difference.
So, what happens if a patient's pressure ulcer gets progressively worse during their stay? Well, here's your progression cheat code. You actually have to report 2 distinct codes. First, capture the exact stage on admission. Second, report the highest stage reached during the entire encounter.
Level 3 takes us deeper into the musculoskeletal system. Beyond identifying the exact bone and laterality, your core rule here is figuring out the root cause of a break. Pathologic fractures happen because an underlying disease weakened the bone, like it snapping just from standing up. Traumatic fractures result from a severe external force, like a car crash.
Now, what's really interesting is how highly tested this gets with osteoporosis. If an osteoporosis patient fractures a bone from a minor fall, that's considered a pathologic fracture. The trap? Never, ever report a traumatic fracture code for this. You have to use the M80 series, which requires an exact site identifier. M81 is strictly for osteoporosis without a current fracture.
Moving down to Level 4, the genitourinary system. Chapter 14 relies heavily on tracking the progression of chronic kidney disease. The mapping is thankfully straightforward. Stages 1 through 4 map perfectly to codes N18.1 through N18.4. Stage 5 takes N18.5, and end-stage renal disease caps it off at N18.6.
Watch out, because here's the Chapter 14 exam trap. Test makers will describe a patient on dialysis and try to make you forget the mandatory secondary code. If they're dialysis dependent, you absolutely must add code Z99.2 right alongside your ESRD or CKD code.
So the crucial point is this: when we hit Level 5, pregnancy, childbirth, and the puerperium, normal rules completely take a back seat. Chapter 15 codes are the ultimate override. They always take sequencing priority over codes from literally any other chapter on the mother's record.
Let's see how this builds in complexity. The 7th character tracks the strict timeline of the pregnancy. Memorize these cutoffs. Under 14 weeks is the first trimester, 14 to under 28 weeks is the second, and 28 weeks until delivery is the third. We always push for the highest specificity possible based on clinical notes, even though an unspecified option exists.
For prenatal visits, your trap is mixing up normal and complicated care. You only ever use the Z34 series for the supervision of a totally routine pregnancy. The second any complication pops up, you gotta instantly switch over to the O codes.
And our final cheat code for Level 5. Every single delivery encounter mandates a Z37 outcome of delivery code as a secondary code on the mother's chart. Whether it's Z37.0 for a single live birth or Z37.2 for twins, it's mandatory. You can't skip it.
Let's lock in everything we just conquered. Remember, digestive bleeds need active documentation. Skin ulcers require staging for both admission and the highest level reached. Minor falls with osteoporosis mean pathologic M80 codes. Dialysis always requires that Z99.2 tag, and pregnancy codes are the ultimate sequencing override. Internalize these and you'll easily bypass the exam's most common pitfalls.
You've officially beaten level 5. But what happens when the conditions you're coding are completely undefined or result from external causes? Well, thanks for tuning in to Decode Healthcare with Harshal. Keep leveling up those coding skills, and I'll see you in part 46, where we tackle exactly that.